Once surgeons began to realize this, the modern era of browlifting began, in which techniques now also employed maneuvers to disrupt this skin-muscle interface by using a subcutaneous dissection underneath the skin. This led to a rapid evolution of the browlift into the numerous methods that are seen today. In the 1930s, renowned facial plastic surgeon Dr. Samuel Foreman realized that to better correct the forehead lines and lift the brows, the skin should be undermined from the muscle, and the technique he would describe in 1939 became what is known today as the direct brow lift procedure. In a direct brow lift, a small ellipse of skin is removed from directly above each brow, exposing the underlying frontalis muscle. Then, the skin of the forehead is undermined, allowing for the release of the skin from the underlying muscle. In addition, the corrugator muscles can also be directly excised or cut to soften the appearance of frown lines. The skin is then reapproximated, lifting the brows and creating a more smooth-looking forehead. This simple technique, still used today, is quite effective at lifting the brows and moderately effective at improving some of the forehead lines. But it does so at the cost of a potentially visible scar right above the brow, especially in women. As a result, this technique is favored in males in whom thick brows are better able to hide the incision. As a modification of the direct brow lift, some surgeons would instead place the elliptical skin excision in the central forehead, around a prominent forehead crease. This would become known as the mid-forehead brow lift. In a mid-forehead brow lift, the skin ellipses are placed in the central forehead, ideally at different levels, centered around any existing deep forehead creases. The skin is then excised down to the level of the frontalis muscle. The surgeon then undermines the forehead skin to a variable degree, as needed, to efface forehead lines. The frown muscles can also be addressed depending on the degree of exposure. The skin is then reapproximated, thereby lifting the brow and smoothing the forehead. Although the direct and mid-forehead brow lifting techniques were effective at smoothing the forehead and lifting the brows, they lacked in longevity due to the fact that they failed to release the retaining ligaments of the forehead and brow. Furthermore, these two techniques were better suited for males than they were for women, especially considering the placement of the incisions, which could be visible in women. However, these new skin dissecting techniques did serve to encourage further advancement in the coronal brow lift. The coronal brow lift evolved through the early modifications brought about by surgeons like Dr. Hector Marino, an Argentinian surgeon in 1965, who sought to disrupt the skin frontalis interface from underneath. From that point on, the technique would become more effective in the eradication of the dynamic lines of the forehead and frown regions. In the modern coronal brow lift, a long incision from ear to ear is still made, all the way down to the periosteum. Next, the scalp and forehead tissues are cleanly undermined in the subgaleal plane, which allows for easy dissection of the entire forehead and superior orbital regions. In this process, the temporal lines of fusion and arcus marginalis are released, allowing the entire forehead and scalp tissues to be folded over, exposing the underbelly of the frontalis muscle and the insertions of the corrugator muscles. The surgeon is then free to section, score, or resect part of these muscles, thereby freeing the skin up for a more smooth suspension unencumbered by fixation to the frontalis muscle. When the tissues are then redraped, the excess scalp tissue is removed and the incision closed. The end result is a thorough rejuvenation of the entire forehead and brow eyelid complexes. The modern coronal brow lift quickly became the gold standard of brow lifting and exploded in popularity in the 1970s due to its frequent use by famous surgeons such as Dr. Ivo Pitangui of Brazil and Mario Gonzalez Ulloa of Mexico, among others. However, the procedure was still far from perfect because it was fairly invasive, required a longer recovery, and it was still plagued by side effects such as scalp numbness and incisional hair loss in up to 20% of patients. These side effects compelled surgeons to continue to improve on the technique. In order to improve the issue of numbness of the scalp, surgeons needed a way to avoid injury to the supraorbital and supratrochlear nerves, both of which provide sensation to the forehead and anterior scalp. These nerves run closely associated with the muscular layer or directly below it. Because surgeons incised through this layer during a coronal brow lift, the possibility of permanent numbness was always present. In an attempt to minimize disruption of these sensory nerves, a subcutaneous technique known as the Subcutaneous Trichophytic Browlift was developed in the early 1980s. In the Subcutaneous Trichophytic Browlift, an incision is typically placed along the hairline from temple to temple, occasionally extending all the way down to the ears. The incision is placed along the hairline, known as a trichophytic incision, in order to minimize injury or displacement of the hairline follicles. Next, the skin is undermined all the way down to the brows, but in this technique, the dissection is subcutaneous, proceeding directly on top of the frontalis muscle. Next, the exposed corrugator muscles can be directly ablated or partially removed or avulsed to soften the frown region. Then, the skin flap is redraped and the excess skin is removed. The hairline is not displaced back and can actually be brought down if desired. This procedure had the benefits of a thorough rejuvenation of the entire forehead, correcting the forehead and frown lines as well as providing a powerful lift to the brows. Furthermore, the trichophytic technique also preserved the supraorbital and supratrochlear nerves, meaning that the rate of scalp numbness was essentially zero. Despite these powerful techniques, some patients only required a mild lift, which led some surgeons to wonder if a nearly scarless, minimally invasive brow lift technique was ever possible. In the early 1990s, with the advent of surgical endoscopy, this dream suddenly became a reality, giving rise to the endoscopic techniques that would change the surgery of brow lifting forever. The use of endoscopic technology in brow lifting came as a result of the simultaneous work of two U.S. surgeons, Dr. Issy and Dr. Vascones, in 1992. In an endoscopic brow lift, small incisions are made in the scalp, positioned behind the hairline and carried all the way down to the periosteum. Then, the tissues are undermined in the subgaleal or subperiosteal planes on top of the bone, all the way down to the brows, releasing the arcus marginalis and the temporal lines of fusion. Then, the surgeon can score, transect, or resect part of the frontalis muscle and or the corrugator muscles in order to partially disrupt the skin-muscle interface, as in the coronal and trichophytic brow lifts. However, in this procedure, no skin is actually cut. Instead, the entire scalp is undermined in the same plane of dissection as the forehead, and then the entire scalp and forehead tissues are mobilized up and back to lift the entire brow and forehead regions. The tissues are typically secured against the bone with either bone-anchored sutures or specialized dissolvable implants that are inserted into the bone to retain the soft tissues of the scalp in suspension until the tissues have had a chance to heal and hold on their own. Because of the minimal incisions, the endoscopic brow lift can be done very quickly and with a short recovery. It also preserves sensation to the scalp and avoids significant hair loss because no tissues are cut. The endoscopic brow lift is one of the most popular modern techniques of brow lifting today. It's extremely favorable in women with mild aging of the brows and forehead in whom only a mild lift is required. However, this technique is not ideal for patients who require a substantial amount of rejuvenation of the forehead and brow due to severe brow drooping, severe forehead wrinkles, and a moderately receded hairline. The advent of the endoscopic techniques left some surgeons wondering if one could combine the endoscopic method with other existing brow lifting techniques in order to minimize side effects and still maintain maximal outcomes. These efforts led to the development of the Endoscopic-Assisted Bi-Lamellar Trichophytic Brow Lift, first described by Dr. Oscar Ramirez in 1994. In the Endoscopic-Assisted Bi-Lamellar Trichophytic Brow Lift, an incision is made from ear to ear but coursing along the frontal hairline. Then, the skin of the forehead is undermined in the subcutaneous plane, just as with the subcutaneous trichophytic technique, thereby lysing the skin frontalis attachments and maximally eradicating the forehead and frown lines. However, in the temples, the dissection is carried deep, down to the level of the temporalis muscle, which is the same level of dissection as in the coronal brow lift. Next, 3 small incisions are made through the frontalis muscle, and then the frontalis muscle is dissected endoscopically from below on top of the bone, as seen in the endoscopic brow lift, releasing the temporal lines of fusion as well as the arcus marginalis. Then, the exposed corrugator muscles can be ablated or partially removed to soften the frown region. Finally, the skin flap is then redraped while lifting the entire brow and forehead tissues, and the excess skin is then resected. Because of the trichophytic incisional placement, the hairline is not displaced back. In fact, if desired, the hairline can be easily moved down. The endo-assisted Trichophytic brow lift combines the best of all procedures, offering a powerful lift of the brow and rejuvenation of the forehead, while avoiding hairline displacement, temporal hair loss, and permanent numbness due to the fact that it preserves the supraorbital and supratrochlear nerves. The endoscopically assisted bilamellar trichophytic brow lift is one of my favorite techniques whenever a simple endoscopic procedure is not enough for my patients. In addition to the techniques reviewed here today, there are a couple others you should read about. These include Dr. Tessier's subperiosteal lift, as well as Dr. Paul's transblepharoplasty brow lift. Please see the video info below for links to these pertinent publications. I hope you have found this content useful, and if you did, please like us, subscribe, or share it with your colleagues and friends. Thank you for watching.